Jim or Scott that's going to report out. Would you mind coming to the microphone? Each group come up and we're going to start with San Diego because they were our first pilot, and I know that they have thought long and hard about these issues. And then we'll just start as people come into the room. We'll start in order of the work group names.
Good afternoon, everyone. I'm Scott Flynn with Arch Health Partners, chair of the University of Best Practices in San Diego. And our two recommendations are for those folks who present to your clinic with uncontrolled hypertension, we'll start them on a combination medicine. Kaiser uses Prinzide, something like that, that's an ACE or ARB with a thiazide. One pill has been shown to increase adherence quite a bit. And if they're over 55, you add a statin. And the reason why is when you look at the Framingham data, those over 55, adding a statin greatly reduces their morbidity and mortality from the cholesterol. The second recommendation is to track and follow those patients for adherence. And with that, we both reduce strokes and heart attacks in 3 years by, what's the estimate, Jim, based on Archimedes modeling? 220 events. For 10,000 patients, it's 220 major adverse cardiac events we will prevent, and it will save 7.1 million for 10,000 patients. Any questions?
Don Morris, are you in the room? And if you don't mind, we're kind of tight on time and we're running 3-minute report outs. So if you could just go in the order that the work groups are listed up to the microphone and report out what your top 1 or 2 recommendations are, that would be super.
And the 3 minutes includes transportation time.
Okay, we had a nice discussion about several aspects of the Archimedes modeling. I think one of the conclusions was a number of people said they felt that the communicating with the patients about their risks and the family members was really an important aspect that seemed to resonate with a lot of people. And then in terms of action items, one of the thoughts is pulling other sources of data. So self-monitoring data, being able to integrate that in, or self-reported health data, and things like that that can be added in to make these recommendations better.
And I think the other part of the discussion that we discussed was about, similar to what this group in San Diego had discussed, is, it's nice to get those surrogate markers and those things, but ultimately, it comes down to the dollar, and you have to have evidence and data and some modeling from cost modeling perspective about what you're accomplishing in the long term in order to make supportable programs for the long.
Okay, great. Hit 3, and then we'll just start, lining up over here. Practice what we preach. So this is continuous flow. And Phil, you're going to fly. Start lining up. Start lining up in one direction.
Hi, I'm Will Neal. I'm a stroke neurologist, Kaiser San Diego, and we discussed a few best practices that we have found for improving appropriate use and timeliness of TPA. These practices, I got 2 of them, and they can be summed up by education and education. It's going to be education for the ER docs and education for the patients. We've learned as far as timeliness and appropriate use is that TPA is a very misunderstood drug. The thought is that this is an incredibly dangerous drug. If you give it, your patient is going to bleed and you're going to get sued. This is, if you're an ER doc, this is what you're thinking. So what needs to happen is education. And at Kaiser we've done that. Basically saying, look, if you use this drug within 3 hours, you're very likely to help somebody and very unlikely to harm somebody. If you wait too much longer than that, the opposite is true. So it's 2 different drugs. One is a very safe drug if used early and appropriately. 2 is a very dangerous drug in the wrong person. So that's a big one.
The other one is going to be education for everyone without a stroke. So we're doing pretty good, decent on educating stroke patients about stroke. The problem is they've already had a stroke, they know what it looks like. So what we actually need to do is educate everybody else, and that's obviously a much bigger task. But right now, about 90% of people are not showing up to the ER because they don't recognize the urgency. So in order to help timeliness now, at least within Kaiser and I think a couple different groups, we don't need to use very expensive messaging. We don't need to use television. We can use stuff that's already there. We don't need to use nurses. We can use health advocates. And basically, we got to create a simple message. The FAST message is a good start. This can be used for high-risk patients at the medical office buildings or hypertension clinics. And then really, for every single person in California, they got to know the signs of a stroke and to call 911 immediately. And if we can do that, you know, our treatment rate is going to approach about 30%, and that pays off in huge dividends. I mean, the cost is almost cost reduction would be almost infinite because you are essentially, if you're under 65, you're keeping your patient healthy and not suddenly going to Medi-Cal or Medicaid and skilled nursing, which is a lot more expensive care. So you can have a lot of dropped costs. So summary, teach the ER, teach your high-risk patients, teach everyone else. Thanks.
Hi, I'm speaking for our telehealth network group that Jim kind of worked with too. The biggest things that we identified as potential action items are some of the things that we had talked about earlier in our morning sessions, are improving access to patients by using telehealth so that patients can get specialty access care for acute conditions such as stroke, where earlier intervention potentially with specialty care is able to provide life-saving treatment and reduce disability and thus reduce costs. And related to that, moving beyond having telehealth networks be owned by a single delivery system, but potentially be seen as a community-level resource where the eventual vision would be having a telehealth communications tool in every EMS van in order for us to provide the right access for care for everybody, regardless of what plan or health delivery system or hospital the patient's being delivered to, but for every patient in the state of California.
We have group 6 and 7 to line up over there. Others?
And we've missed Jerry Prince's measure of pressure down. Jerry, would you mind lining up? Oh.
So Hector, okay.
Okay, I'm Michael Cantor with Kaiser Permanente, Southern California. We talked a lot about it, addressed the issue of multicultural populations and cardiovascular prevention. A couple key points we wanted to convey. One is that it is possible to achieve the good outcomes, even the 90th percentile, in the various HEDIS measures that prevent stroke or cardiovascular disease in an ethnically diverse population, and within each minority group per se, one can get control rates that are that high. And so part of what we would encourage is a sort of just do it attitude, and not to try and use a diversity issue as a excuse for not hitting targets. So we then talked about how we actually see disparities and don't know what causes them exactly, but believe that there's a large role for health education, pretty much for everybody. I think we just heard about that from our stroke folks, but this needs to be tailored to a patient's educational level, culture, but huge opportunities in figuring out how to promote and encourage better education for our patients so they know exactly what their role is in their own care. So the second big item that I think we just need to do it and put more effort into it. Trust and community relationships become key in a diverse population. The delivery system can't do everything itself, and we need to get better community partnerships and work more collaboratively with each other. So those are the key points that I think we need to move forward on. Thank you.
Excuse me, Hattie, just to let you know, to support Mike, there are handouts on everyone's table.
Oh,
With,
wonderful.
an
Thank
outline.
you for bringing those, Ray. Ray Bogany is a San Diego hero who has brought the San Diego Kaiser from trailing the rest of Kaiser to being at the national A-grade of performance, and just a special little moment for Ray.
So I was part of the Measure Pressure Down campaign group, which is a national initiative spearheaded by the American Medical Group Association. And we talked mainly about three of the main areas, which were performance, measurement, and feedback with respect to blood pressure. So there was a real big recognition in the room that the groups that are engaged in improvement in this area start with believing the data, making the data more believable to clinicians. So training medical assistants on how to measure a blood pressure so that physicians believe that blood pressure and act upon it as reliable information. So that was number one key recommendation. Number two was, it was clear that everybody that was at the table in one form or another disrupted their clinical workflow, either to task medical assistants or pharmacists or another care team member with some responsibility, and that is one of the process planks. But it seemed to be one of the areas where people struggled with and didn't seem to have a perfect solution to. And then finally, we talked a bit about the importance of adopting a medication protocol for hypertension. And there's many good models out there. I think there was some recognition that there's sometimes resistance if you import a protocol from another organization, and how it's important to manage the change as you integrate a protocol into your organization, make it yours. So those were the three key elements that we talked about.
This group should start lining up in groups 8, 9, and 10.
Okay, we were group 6, pharmacy role in stroke prevention and management. I took the notes, I was the only one that could read them, so that's why I'm up here. We have kind of have 4, but they fall into 2 in 3 minutes. Basic idea was to leverage the community pharmacists, and the community pharmacies are where so many people, patients and their families and caregivers go into those community pharmacies. That's the overall idea. First step is to recognize the community pharmacists and other pharmacists as providers. As Rebecca reported up here in Senate Bill 493, that is already happening. The next big step is then to align incentives with these providers, with all of the providers and the medical groups and the pharmacists in the communities. If they're trying to reach the same goals, they have the same incentives, and the payment is coming from the shared risk pool. So it's not necessarily just fee for service, it's a sharing of incentives and payment mechanisms. And the payment mechanisms would be for this interaction with the pharmacist, a quick interaction at the pharmacy level with patients and their caregivers that are picking up prescriptions already. And it'll be something like a really short checklist. And let's say it's hypertension, we're trying to reduce stroke, you're picking up your antihypertensive. The questions are, what was your last blood pressure? Do you know it? Do you even know what your numbers are? And then how adherent are you? Get the patients to be thinking about this, if they can answer that or not. Do they have an appointment for their next PCP visit to actually measure the blood pressure and to have follow-up? And if it is the patient, there could be a quick blood pressure measurement right there at the same time. So it's utilizing that intervention right there at the time. So the patient or the caregiver are already there in the system. To make this the lower cost, what the fourth piece is to actually leverage more of the technicians and not the pharmacists. And to do that, we need to expand or at least realize the scope of practice for technicians and improve the training for pharmacy technicians so that it is somewhat consistent. And they would fulfill a large portion of this role with the pharmacist stepping in when they got to a point where, oh, okay, a pharmacist intervention would be warranted there. So unless my group has anything else to say, I think that was our summary. Good.
I'm a stroke neurologist from LA County Department of Health Services. So our group talked about gender differences in stroke. As many of you know, stroke declined to the 4th leading cause of death from the 3rd. However, those improvements haven't been seen in women. They were primarily driven by improvements in men. In addition, although women are disproportionately affected by stroke, they're still found to be less likely to receive interventions. They have longer door-to-needle times, door-to-physician times, and their risk factors are less likely to be controlled, although they may be more likely to be treated. So, and finally, they have gender-specific risk factors, and certain risk factors affect women more than men, such as metabolic syndrome, which is a big deal in the growing obesity epidemic. So we had a few strategic initiatives that we thought might help. One was obviously education. We have a lot to learn from other campaigns, such as the breast cancer campaign. Also, one thing that would be helpful is to develop stroke-specific gender-specific risk calculators, as the current risk calculators don't work as well in elderly women as they do in men. Also, algorithms and protocols definitely help. Hospitals participating in Get With The Guidelines who have strict protocols in place do better with respect to sex disparities. And basically tech innovation, using apps for stroke risk calculators, the importance of getting imaging fast, and not letting people's potential biases. A lot of physicians think that women are at lower risk for stroke than men, so not letting those kinds of biases affect care. And the initial title was about differences in stroke presenting symptoms, so they are less likely to have the typical stroke symptoms that men do, and yet that doesn't completely explain the difference in their time to treatment. So it's more than just presenting differently. There's something else that's involved. So those were our recommendations.
I'm Robin Clark from UCLA. I'm the co-chair with Deutsch of the LA Best Practices. So we wrestled with healthcare and moving from healthcare to health, and we didn't come up with the answer. But we blamed it all on LA and the size of the county, the heterogeneity of the population, and the difficulties there. So we resolved a bit. No, but we did agree that moving from healthcare to health is extremely complex. Moving from the experience where it's been focused within our medical groups, and our medical groups are innovating. We are trying to expand the care teams, the primary care model itself, and move more and more towards partnerships with community groups and non-physician providers. But taking that next step and moving beyond health systems and responsible populations and moving towards thinking regionally about community-based health and populations at large is going to be a whole other step. And we've discussed a lot of different ideas. If we were to do something like a regional LA-wide blood pressure campaign, how difficult that would be, and how complex it would be to yes, you could identify the population, identify those at risk, but then tapping them into an existing health system and developing the appropriate partnerships is going to be extremely complex. But we had a very good conversation, and we are an active group now. I've been meeting in LA for the last 6 months and starting to coalesce and and looking to the other regions to inform us about next steps going forward. So no recommendations, but maybe next one.
Good afternoon, I'm Jose Alberto Revalo, and I'm the co-chair of Sacramento Right Care Initiative.
I'm the other co-chair.
And we wanted to show our partnership up here. We are just out of diapers. We celebrated our first year, although it's been it went by very, very fast. What we wanted to, what we were tasked to do is to talk about a prioritization process that we went through after having had some great presentations, including presentations that you heard from the Stanford group. Our group sat down and went through a process to prioritize, really with the help of Dr. Hector Rodriguez. Hector, where are you? There he is, yeah. He came with us, and we did a really nice prioritization process. Thank you. And we had a session where our group got together. We identified a bunch of items, and through a prioritization process, our first item that we recommended that we'd like to undertake is education of the highest risk patients and their families. For instance, those who have experienced TIA, about signs and symptom recognition, and you've heard all of this before. Our second item that number 2, was risk factor mitigation education for high-risk patients and their families. And then number 3 was intensive regional efforts to have high-risk patients use home blood pressure monitoring. So it was a real nice process, and again, thank you, Hector, for going through it.
Yeah, and then at our table, we had some discussion about how do we actually implement those things in various models. So from one of the things that came up with is potentially utilizing some of the nonprofits like American Heart Association and so on to reach out to them to do more education. And of course, we had Matt from Travis Air Force Base, so I asked him if maybe we should just enlist everybody in the military. No one would take the medications, but he said that doesn't even work. So, thank you.